guess, official, formal start of CHESS 2022. We had a great day of postgraduate courses yesterday, and today we'll be getting into the meat of the meeting. I'll be your host, Dave Schulman. We've been part of the Interruption for a number of years. This is our first foray into doing it for sleep. So before we formally pardon the interruption, I want to pardon the introduction. Introducing our competitors for the morning. The Midwestern Mauler, the Buckeye Gone Awry, hailing from the Ohio State University School of Medicine, Dr. I just want Anissa de Action Das. You don't need to root for her yet. No, okay, don't root for her yet. She may start to say terribly silly things. Don't root for her yet. All right, moving on. Jumping into the fray from the city by the bay, the emboldened great from the Golden State, hailing from the University of California, San Diego School of Medicine, Dr. Be Cool, Stayan Atul Malhotra. Atul, welcome to the octagon, I guess, of some sort. You're the one on the left in this picture? Just checking. And lastly, sitting pretty in the Windy City, the real McCoy from Illinois, hailing from Northwestern, Dr. Lisa Big Bad Wolf. Lisa, welcome to the octagon.
Well, thank you.
Thank you. All right. So, again, our first foray, but we got three really smart people who have really strong opinions and may not know what they're doing. To my right, governing them all, will be my partner in crime, Dr. Neil Friedman. He's temporarily behind it, but he's going to be keeping an eye on them and keeping an eye on for later discussion. Here are the rules of engagement. We have briefed our competitors, but just for the audience's purpose. We're going to get to a lot of topics. We have, I think, 14 planned. We may or may not to get all of them. For most of the topics, I'm going to select the speakers in a random order. I may occasionally go to one. Speakers have been counseled to keep their comments relatively brief. I get bored relatively easily. They all know me. I have a very short attention span, so I will cut you off if I need to because I'm just getting tired. In the order of importance, volume, humor, and accuracy. And those are the things on which you'll be graded. I reserve the right to cut you off, as I said, going long if you're off topic or you're just annoying me, and Neil will counsel me if he feels that that's going on as well. For each topic, a contestant can earn up to 4 points. Half of those are for data and facts. Half of those are for a good snappy bit of sass. If somebody comes at you and you are successfully sassed, I reserve the right to deduct points from you. You can sass me, feel free. I love a good, but if you come at me, bring your A game because I absolutely will come back at you. And then new this year, for those of you in the audience, hopefully everyone got a little paddle. Hold up your paddles, please, everyone. If you're happy with what a contender is saying and you're in agreement, please show me a thumbs up. If you think the contender is full of crap and you disagree with what they're saying, feel free to give them a thumbs down, and I will score accordingly. Also, for those of you who are Twitter avid and want to kind of hear a little bit more about a topic, Dr. Friedman on my right is going to keep an eye on that Twitter hashtag. You can ask questions later if you want to hear things, but if you want answers fairly proximately, feel free to tweet at that hashtag ChessPTI, and we'll keep an eye on them. Okay. In that context, contenders, are you ready?
We are ready.
You are ready. All right. Good luck to all of you. We'll start with the first topic. What's it good for? Does CPAP make a meaningful difference for anything other than daytime sleepiness? Start with Lisa Wolf.
Well, I think that there's going to be a lot of agreement here that in very severe patients, that therapy is going to be good in terms of CO2 control for, say, obesity.
But that's obesity, hypoventilation, not sleep apnea. You're referring to?
Well, I think that if you're thinking about CPAP as therapy, 60% of those with obesity hypoventilation are going to get treated with straightforward CPAP.
Fair enough.
So I think that that's a legit thing to say about CPAP as therapy. We don't have to go as aggressive as we go most of the time for hypercapnia. Oh, one other thing. Marriage is staying together.
I was going to say.
Yeah,
I
think
bring more
that's a good
couples
thing.
back to the bedroom than a marriage counselor.
Yeah,
100%, yeah.
I think it's a legit goal of therapy.
Dr.
Right.
Malhotra.
But anything other than sleepiness, it certainly improves like blood pressure surges and stuff like that. I also think a lot of these people we call asymptomatic are not really asymptomatic. So when you actually talk to them, they feel so much better. Snoring is an important outcome that we often ignore. I recently wrote something saying, why do we ignore the chief complaint in snoring? People come in and say, I snore, and you say you don't have sleep apnea. We don't do that with any other disease. Somebody comes in with shortness of breath, you don't say, you don't have asthma, go home. You treat their symptom. And
Cardiovascular benefits? Anything there of meaning, of significance?
I think it's soft right now, so I don't tell patients we're going to prevent a heart attack because it's a lie right now.
I'm just going to say I would like to deduct points every time Dr. Atul Malhotra references a paper he wrote himself.
Okay. Let's talk about the Padre.
Whoops, I keep... that all you
Yeah,
have to say?
I kind of said my piece.
You
I'm
lose,
like
a,
interrupting
you lose a
everybody
point for having nothing of interest to say. Okay.
Yeah.
So next topic, mildly entertaining. Should we treat mild OSA? A nice follow-up to that in the absence of daytime sleepiness. Anissa, you had nothing to say last time. Maybe you have something on this.
So it's interesting because I think one thing that Dr. Atul Malhotra said, and these are actually very similar questions.
If you reference his papers, is that okay?
I get extra points for that.
Okay.
Yeah. No, but I think one thing is the number of people who really don't understand that they have daytime sleepiness. The number of people who come in saying, I feel fine, and come back on CPAP and they're like, oh my God, I feel so much better, is profound.
You know, I'm going to call you out on this, Anissa.
Okay.
And I am going to say that there can be some disconnect, but if you look at sleepiness as a marker of cardiovascular disease and the marker of risk of cardiovascular disease, which is sleepiness being one of the best ways to do that, we didn't go to those people and say, hey, you say you don't have sleepiness, but you're lying. No, we didn't. We took them at their word. We said, rank your level of sleepiness, and those who had the highest level of
Right.
sleepiness had the highest risk of cardiovascular disease. So I have to take them at their
Okay.
word in terms of that risk.
So what I'm going to say is
Yeah,
you're
I
not
think
going to force them on it. Okay, go ahead.
I think in the area of patient-reported outcomes, you can't ignore symptoms. I think it's just, that's just wrong. But I will say the question's not good because the scale for mild, moderate, and severe is kind of silly. It's made up
Yeah, it's
numbers.
kinda
and
crap.
it's
Oh
not-
my God.
And AHI is a crappy metric as well.
Yeah,
Right. So that's-
AHI is the worst.
Yeah, so
It's the best we have, but it's the worst.
Yeah.
So if
Well-
you have one patient with one REM and they desat to 45% and their AHI is 100 in REM, and they had 10 minutes of REM and their overall AHI is 5, are they? Right?
Yeah,
So yeah, I'm gonna try to treat them probably. And I'm gonna give them a trial, and if they say they feel better, even though they told me that they weren't sleepy, then I'm gonna give them treatment.
So you're saying you
But
don't
you
believe the
can't-
patient, is that
No,
correct?
I'm saying I tell everybody, let's give you a trial, and I don't force it, right? So there's one thing to say you have to treat this mild sleep apnea. There's another to say, do you want to try? You might feel better. If you don't, then let's stop.
Listen, all I can tell you is that you can say that, but what you cannot say is that by doing that, you're going to prevent cardiac disease, you're going to prevent them from having metabolic issues, you're going to prevent them from developing worsening hypertension. You just don't have the data to say that.
Did I say that?
Can I really not quote my own papers? Is that?
Neil, jump in.
So can I ask a question?
No,
Or-
we had
or
a
comment?
meta-analysis, mild
You
sleep apnea.
lose a
had the
point
blo-
for
had the blood-
asking if you could ask a question. Just ask the
Mild sleep apnea
question.
had the same blood pressure.
I want to go
preference.
back to the last there, but so the
agreeing with you.
treating people who are not sleepy, so they're sent in, they don't really care if they snore or not. They've got bad sleep apnea, should you treat them?
So,
Like the AHI is 35, whatever it happens to be, based on the data, should we be treating people who don't have symptoms?
And they're asymptomatic?
Yes.
I dig into asymptomatic. What do you mean by asymptomatic? Some of them have 8 cups of caffeine every morning, and they say I'm asymptomatic. It's like,
Their
well,
wife sends them in because they're snoring, they don't care,
but
they're
they-
sleeping in
but
a
a lot of
separate
them-
room.
a lot of them
they're
say I've
not
never
tired."
felt so good when you treat them, right? Boy, I've never felt so good, and you said you were fine, but now you're so much better.
So-
a lot of them are putting a Band-Aid on it with coffee. Or
So is there anybody you wouldn't treat then? I mean, you're basically saying, I don't trust the patient. Patient says they're fine, I don't
I
trust you. You
didn't say
don't
that.
know you're fine
didn't say
until I
that.
treat you.
I have that conversation. I said, I hate to agree with. So,
You do lose a point for agreeing with Anissa.
But
wait, and you're agreeing against self-interest, because it's not what your own paper said.
yeah, but the other thing is, which we haven't talked about, is what about age of the patient? I do think there's a declining
Oh.
benefit in certain ages. So I have a lot of 80-year-olds who say, I hate the CPAP. I don't care if I have an AHI of 50. And I'm like, I don't really care either. Don't use it.
so my favorite story there is when George Burns turned 90. They asked him, what does your doctor think of all your drinking and smoking? He said, I don't know, my doctor's dead. And so
He
I,
gets points for that.
Yeah,
gave
he
him-
does get points
Okay,
for that.
and you lose a point for telling me when he gets points. I am the only one who decides when people get
where are
points.
the green things?
No, I don't see any.
Yeah, they're not just you. Yeah,
That was good.
shouldn't have to ask.
No, the only thing that I'm going to say there, and I am going to throw this out because I actually think it's a serious point, which is that in the setting of mild intermittent hypoxia, aging goes better. Healthy agers have a little bit of apnea. They have a little bit of intermittent hypoxia. And I have to say that we know that that stimulates BDNF, it stimulates NGF, it increases branching and pruning centrally in terms of cognitive function and helping to keep patients alert.
So
There
should
is
you
a
not
day.
treat people then because it's good for them?
So what we're talking about specifically is the elderly patients that Anise is talking about.
That have no symptoms.
But they've already
So-
survived. They've got a survival bias there because you're looking at people who've made it to a
But
certain age.
I'm gonna call you out.
You're going to call everybody out, but give me facts.
I am giving you facts.
Go.
So the fact that I'm going to tell you is that apnea-hypopnea index as a normal value changes over the age span. And I don't think it's right for us to say 5 is the number that I'm looking for everybody. If you are 6 years old, 5 is too high. And if you're 80 years old, 5 and 10 and 15 is probably just fine. So
You know,
I think we need to do that.
Yeah, we tried to model that survivor effect. Is it really that you're killing off so many people that it's protective afterwards? It's really hard to do that, and it doesn't exist with hardly any other disease. You can't, it's just not plausible. So I agree, probably the normal values changed, although it is hard to define normal when everybody has some abnormality.
Host prerogative. Let's move on to something that's a little bit more topical, perhaps total recall. Was the Philips recall much ado about nothing, or do you believe patients were really having side effects from foam breakdown? We'll start with Dr. Das.
So if you look at the data of the MDRs, right, the medical drug reports, there were only 30 reports in 10 years before the attorneys decided to advertise it. And now there's, more than 20,000. And there were no deaths. So I think that's important. And it wasn't necessarily reported out as transparently as it could have been, so I think there was a little bit of confusion. And all the subsequent, and when I say all, there's 2 papers, right, on cancer risk, have not shown that there's been a cancer risk at least.
That was mine.
The one thing that I will say is the epidemiology study that looked at the group in Sweden had higher numbers because it also had much higher smokers. And I think one of the things you need to think about in terms of the PUR stuff is that it may be similar to other cancer models, that you need 2 hits. You need to have one hit that increases your risk and a second hit that increases cellular proliferation. And I think to that extent, there's still risk there that may not be able to be captured by epidemiologic
Yeah, so
data.
we had a paper in the Blue Journal. Tatiana Kanzerska from Toronto looked at cancer risk, and it's basically 0 difference between any manufacturer. So I don't think that risk is real. In terms of other stuff like upper respiratory things, I'm just not seeing that clinically. I do see it though from SoClean when people are using that cleaning thing.
Yeah,
then you
that's
see
the
use-
worst.
That's the worst, and that sort of worsens the foam breakdown as well. So that I think is a clinical issue. I don't think what manufacturer. I don't think that matters.
That might be the best thing that's come out of the recall, is that we've all been more vigilant about stopping SoClean.
What do you do with patients who may or may, let's say they don't use SoClean and they start complaining of respiratory symptoms, sort of vague respiratory symptoms that may or may not be induced by their CPAP machine?
What do you do if they're using SoClean and have symptoms?
No, either way,
Attempt to get rid
regardless
of
of whether they're using SoClean or not.
Yeah.
I think my CPAP's causing me to feel dyspnea, cough, what have you.
A recalled device you're referring to?
Yes.
specifically?
Replace it.
Yeah, get rid of it. They shouldn't have it anyway.
Well, you're going to be waiting for a year for that. Well, at least now maybe not so much. But what would you have done a year ago in that context?
Well, we look for other treatments to bridge them over.
Non-PAP.
We look for non-typical US devices to get them over. And the truth of the matter is most of the people want to blame their CPAP so they have a reason to stop
Do you think
it.
it's real?
I don't
So you
think
could-
it's real.
Do you think it's, Anissa, is it real?
No.
Atul, real?
The symptoms?
Yeah. Non-particulate, just I feel dyspneic.
No.
Okay.
I
So
will
there's a
say that I've had a lot of complaints about those B3 or 3B or whatever the hell
Yeah.
that is from overseas. It's a piece of junk as
Yeah,
far as I'm
that's-
Patients don't use it. Totally agree.
Can I just say one other thing, though,
Of course.
about that whole
Stop
thing?
asking. Just say it.
Sorry. One of the issues that I have in people who say that they're having all of those symptoms and it's quote from their CPAP, get the download on those guys. They typically have super high mask leak. And what they're really getting is drying due to the mask leak, and that's what's causing the symptoms. And if you just get a better mask fit, it'll get better.
All right, nice.
Optimize the humidifier and stuff, I agree.
Now it's so much harder to get the downloads though, because none of the devices send data directly, so you have to get their manual.
You missed
We've
the
gone back.
3G
know.
network. You all
I
missed your 3G
know.
networks.
I know. Nobody laughed at my tweet about how I feel like I'm back listening to Pharrell sing Happy, because back
Okay,
then
you
in
tweet like
2015
4 times a year. That's the problem. You
Actually,
tweeted more
you
often.
need more than 10 followers.
That's the issue.
Okay, but what the point to the tweet was is that back in 2015, people came in with little cards, and I thought I was such hot shit.
Finding your tweets
You
is
know.
harder than finding a download from a 3G device these days. It's just you don't do it often enough. I'd give myself a point for that. Yeah, see what I'm saying? She's not easy. All right, next topic. Again, talked about alternative therapies for sleep apnea. Is drug therapy for sleep apnea ready for prime time? Lisa Wolf,
So what I'm going to tell you is it depends.
because
You wanna
you're
start?
going to tell me about the paper you wrote.
Can I talk about a paper he wrote?
I don't care.
Okay, so I'm going to talk about your Lunesta paper. What I think is that if you look at OSA based on phenotype, one of the phenotypes that we're going to see is the arousal phenotype. And I do think that sleep consolidation with the aid of a hypnotic to reduce apneas in those with arousal phenotype is probably ready for prime time because we can control it and it's mild. That is a huge difference from saying, hey, have some amoxicillin, right? Have some oxybutynin with that. I don't think that stuff is ready to go as single therapy. So I think that we have to just look at this stuff and have a healthy respect for the phenotype issues that drive it.
Dr. Malhotra.
I don't think any of this is ready for prime time. I've done some of the research in this area, and until we have multi-center randomized trials showing it's better than CPAP, I really don't think it's the way to go. If you're using it as a CPAP failure, then we need rescue studies that compares it to other rescue approaches. So I think right now I conserve physiology, and that's why we call it research.
You think it works, but you don't think because there's no comparative data comparing it to OAT or something
There's
else.
lots of things that work in theory, or they work in, but until we have patient-reported outcomes saying patients prefer this to that as a rescue approach, we don't have that now.
Anissa.
Yeah, and what if I'm always last? And I'm like,
You're not always
"Oh,
last. Stop. You are first sometimes.
Take a point away from
I am. Okay, I'm taking a point away from her, and I'm taking away a point. Stop telling me where to take points away from people. I'm going to give her the point back and just take it away from you. All right, Anissa,
All
still.
right, so I do think that the problem with using Lunesta for the arousal, which I agree with in theory, is it's hard to figure out exactly which patients those are going to be that are going to actually help, right? So because we don't bring them back always on the Lunesta. If we did that, I think it'd be one thing.
I think the other big limiter to that is the fact that HSTs aren't giving us that information anymore.
Yeah.
And the biggest thing that we lost as we transitioned into home sleep testing were the intangibles, that your actual doctor who knew you was looking at every one of those things and thinking about your complaints and how they fit into what they were seeing.
I will say one other thing, in that clinically, the patients with sleep apnea and comorbid insomnia, I think those aren't well studied. I don't think they do well with CPAP in general. It's a big chunk of older patients, maybe a third. I think that's probably the group that we should focus on in randomized trials. I do use it clinically there sometimes if I don't have another option, but I don't think the data aren't there, but that is a group that's very understudied.
I'm going to give you last.
I just like to point out that in the end, he did agree with me.
Noted. All right, let's move on to a non-respirology topic. Narc. What is the appropriate management of narcolepsy in the context of pregnancy and breastfeeding? All right, Dr. Das, you're always complaining you're going last. Why don't you go first on this one?
So I always take the approach of if you can come off of everything, try to come off of everything. Like I would rather have you not put any drugs into your fetus and not do it through the breast milk either, if feasible. That's not always feasible, right? Like it's easy.
Is it ever feasible?
That's the easy That's the easy answer. The reality is,
We're in Tennessee.
All right.
I'm not touching
all right.
Just on so
I'm
many
not-
levels,
I'm not
I would
touching
not go there.
I'm debating the point thing. I'm going to hold off thinking about that for now. Go ahead.
So then I think that being said, I try to get them through the first trimester. So all the bits and pieces are there and then put back in what they need to. And then for the breastfeeding piece, the one that we actually have some literature on is Xyrem, right? So Xyrem is out of your system in about 10 hours. Katie Sharkey's paper showed that from Brown, not Dr. Malhotra, but she did. And it was a case series. It was a small group of patients. But the concern is, so their recommendation was, if you're going to use Xyrem, you can pump and dump, and then use it. So that's one option. The other interesting thing is I started looking at the literature in ADHD. There's a lot of folks who stay on their stimulants through that.
Yeah.
And there's a lot more for methylphenidate data for that because of the ADHD.
Just a couple of other things. One of the super important things is no matter what you're giving them, if you're giving it during pregnancy, you have to stop within 2 weeks of anticipated delivery, because what you don't want to have is the baby go through withdrawal at the time that they're born. So that's a really important way of protecting the baby. And then the other thing is the SSRIs that are used for the other symptoms for narcolepsy have many of them been very well studied in depression, and we know that they're very safe for depression. Fluoxetine specifically being one that's been studied by psychiatry. So I do think we have some other options if, like you say, we look at these studies for other uses of the drugs.
Yeah, I don't have a lot to add, but I will say two things. One is nap therapy. I think that's sort of underutilized, but people feel a lot better if they take a nap. I have patients who are dentists or doctors or whatever that schedule a nap in the afternoon. They wake up feeling fine. They don't need Ritalin if the nap is working. And the other thing, I just saw a patient on Friday who did really well with behavioral treatment for cataplexy, just controlling emotions and doing that kind of thing. It doesn't sort of freak out as much and doesn't get the cataplexy. So I think there are conservative ways of managing these things if you can avoid drugs.
They've been trying to give me controlling emotion therapy for 5 decades, and it has not kicked in yet, but they're working on it hard. All right, let's see the future. AHI, RDI, hypoxic burden, other metrics. What actually predicts cardiovascular risk? You want to say, Dr. Malhotra, you have the floor, sir.
Well, not allowed to quote myself, so I'll quote my
You can
trainee.
quote somebody else quoting you
My
if you
trainee,
want.
Scotty Sands, has published a lot on this. It's nice. If you look at 4% DSATs, that predicts hypertension. 2% DSATs predict insulin resistance. Duration sat below 90 predicts platelet aggregation. Frequency of arousal predicts memory consolidation. And nothing predicts motor vehicle accidents. So the answer is it depends. And it's going to depend on what is the outcome of interest. The idea that one yardstick would predict car accidents, heart attacks, and diabetes, and neuropathy, and Alzheimer's, and cancer is implausible.
I'm going to add one thing to this because it's one of my big pet peeves. One other thing that predicts nothing is actual nadir. If I see one more sleep study report out the O2 nadir as if it's some very important number, I'm going to lose my mind. People need to start putting either a T90 or a T88.
But the nadir gives shock value.
Well, so I'm going to call it out the way I see it on this one. There are too many sleep docs who, for whatever reason, have a vested interest in getting that guy CPAP. And when you put out numbers on your report that clearly have shock value, there's an ethical problem with that. Your patient that you talked about who had a REM index of 100 and a total AHI of 3, right? Why is it the report puts out right up there, up front at the top, a REM index of 100? We just need to be ethically more upfront about this stuff.
I think the nadir is probably not reproducible either. A lot of those are
Yep.
artifact, and it just doesn't vary night to night, so I think it's probably garbage.
Yep, needs to come out of there.
So when you talk about 2-4% DSAT protecting things, Dr. Malhotra, does the starting point matter? Meaning if you go from 96 to 92 versus 91 to 87,
I think
both
all-
of those are 4%
yeah,
DSATs.
I think all that matters. I think this hypoxic burden that Ali Azerbaijan and these guys are working on is an area under the curve, and I think all that matters in terms of that. The hypoxic burden, that we need more data on that, but it looks pretty good as far as cardiovascular risk prediction, and it takes into account, the area under the curve.
We
So
don't report area under the curve, right? We report time, but we don't actually multiply that by depth to give you that AOC.
we don't yet, but I think that's where things are headed, I think. But that's not going to predict cancer and Alzheimer's and heart disease, and it just...
And to some degree, let's be honest with ourselves, there's double dipping involved. If I have a history of smoking and underlying COPD, I know my biggest risk factor for mortality is actually cardiovascular disease, right? We know that without doing a sleep study on anybody. But we also know that when you have an apnea event and you have underlying COPD, you are going to get bigger drops. So are we double labeling these people for a risk we already knew they had? Just going to throw that out there.
Next topic.
It might be
Go
real,
ahead.
though. Like, we have some papers on combining sustained and intermittent hypoxia. If you have sustained hypoxia from COPD or altitude or whatever, and intermittent hypoxia from sleep apnea on top of that, it may really be additive stimuli. It's not double counting, it's really additive.
Let's move on to a related topic of stimulating conversation. Should wake-promoting agents be offered to sleep-disordered breathing patients on therapy who are not adherent to CPAP for at least 6 hours a night? Dr. Das.
Well, there's actually literature that would support that. They've done studies that you can, and I think it depends on what you're doing, right? So the person who's partying all night, you have to treat patients, but there is literature. So first is yes. Secondly,
So wait, you're saying you treat patients now, but you weren't listening to them when they told you they were asymptomatic at the beginning of this debate. I'm just going to point that out. Never forget.
yeah,
And I'm going
Well, no,
to.
I want to let her continue. Chase, I
Okay.
did interrupt her. That's on me.
no, that's okay. I interrupt. I
Oh,
don't
wow.
mind. I got you,
Giving
Bill.
control
Go
of the
for it.
board away. Okay, whoops.
I'll come back.
Okay, so what I'm going to say is that there is an issue there. that includes diversity and equity that we are not talking about. And there's data that has come from SciPartha looking at actually the 4-hour rule for CPAP and saying if you are a person who has to have 2 jobs in order to make your life work. If you are a person who lives in a house that has multiple generations in it and you have limited space in which you can sleep, getting to that 4 to 6 hours is not realistic because of your social constructs. Who are we to say whether or not that's right or wrong? Don't we meet our patient where they're at and give them the best for what they need? So that's the diversity equity issue. In addition to that, there's a public health issue, which is that I have a responsibility both to my patient and for the fact that if they're going to admit they're sleepy at the wheel, that they are going to have a public health problem down the road. And I think that I'm just as obligated to treat that as I am to look at my patient.
Well, I agree, and I'm going to backtrack on what I even said too, but I stand by, yes, we can, there's data to support it. It's also our job to make sure that we're treating behaviorally induced insufficient sleep syndrome, right? And so I think the number of patients where I extend their sleep and it makes a massive difference is profound. So if you ignore it, and I recognize that there's some people who can't, right? So asking them why, and I think listening to your patient makes sense, but there's a lot of patients who say, can I just have a pill?
I don't think
Go
we have
ahead.
data that we prevent car accidents or these things either. That's sort of an assumption that, oh, you know, why would you put them at risk of a car accident, so give them the drug? It's like, well, the onus is on these companies to sort of show us that that's
No,
being
but-
prevented. But the
but
other thing I'll
what
say
we
is,
do
even
know-
among poor people, you know, I understand the point about diversity, but you know, they still need adequate sleep. And I think it's putting a Band-Aid on a problem to give them a drug rather than encouraging them to get adequate sleep. And we have data now on dose response in terms of CPAP. I think the Medicare 4-hour rule is silly, but the more they use it, the better, and I think that should be the emphasis of the question, not, you know, the drug.
The only thing I'm going to push you on the car accident thing is, yes, we don't have a way of predicting based on any of these values who's at risk of car accidents. I agree 100%.
Nor
But
that
what
the
we
drugs
do-
the drugs don't
No.
necessarily prevent it either, right?
No, listen, I agree with all of that. The only thing I am going to say is the one thing that does predict car accidents is the person who admits that they're falling asleep at the wheel. And so that's why the first question needs to be, are you falling asleep behind the wheel? Have you had near misses? Because that does predict.
We also have data on hours of sleep in accidents. I mean, I can quote my own things on that. So there's lots of data that less hours you've slept, the higher the likelihood that you're going to actually be in an automobile accident. So I think that goes back to, if you want to talk about our responsibility to the community, it's to make sure you say, hey, if you're not getting enough sleep to be able to drive safely, then you can't drive. I've said that frequently.
So I think all the more reason, if people say that they're drowsy at the wheel, all the more reason you want to encourage them to get adequate consolidated sleep, not give them a pill, because the assumption is that the pill's going to prevent that, and it doesn't, or at least not that we know of. And all the more reason that you should encourage, you know, you need more sleep.
Yeah, I am hopeful that we can impact our patients' behavior that way. If you know that realistically the social situation of that patient is that isn't going to happen, at some point, are we being judgmental and denying safe care? That's all I'm going to say. I agree, in a perfect world, they should.
Who's going to pay for
I
it?
agree, and I'm not saying I wouldn't give the medicine, I just would emphasize other things first, and I think we're agreeing there.
Yeah, absolutely.
I'm going to move us
100%.
on, right?
No
It-
green thing, you know, come
I've
on.
inserted
Yeah.
this.
Yeah, thank you.
Yeah, they've been
Shouldn't
lulled
have to-
in, they don't,
shouldn't have to
they're,
beg.
they're worried about intercalating themselves into this debate. All right, so this is a topic I threw in because I have very strong opinions about this. Awe-inspiring. Aggressive advertising for Inspire, appropriate or problematic? Dr. Malhotra, we'll start with you.
Well, I should disclose conflicts. That I'm running a trial for LevoNova that's a competing technology, so I'll just say there's a disclosure.
Thank you for reporting.
You know, I think it's a double-edged sword. I think there's a lot of patients coming in asking about it, and I think in some ways it's a good thing in the sense that a lot of patients are coming out of the woodwork that didn't want CPAP, had never heard of CPAP, or heard horrible things about CPAP, and those patients end up getting appropriate treatment. So our estimates are about 1 billion people worldwide with sleep apnea. I don't think Inspire is going to put a dent on that number, but I think there's a huge number of patients that are untreated, and the fact that they're coming into sleep clinics now, I think, is a good thing.
However, okay, so I'm going to take Dr. Schulman's side on this one in that
I don't have a side. I have equipoise.
I am super irritated by the Twitter feed right now and how much Inspire is constantly on it because
Somebody like really aggressively raising the thumbs up in the back on
yeah,
that
I
one,
mean,
so.
it is so biased, right? And that's a problem. And it doesn't say if you can't, so the indications are you have to not be able to tolerate your CPAP. And so it's not you don't like your CPAP, that's different. The other thing that I don't like is they often, if you look at their paper or their website, it says, has not been tested in BMIs over. That's bullshit. It actually has been tested. The very first study that they did actually studied all comers, and it didn't work. The Inspire didn't work because everyone was too fat. So they said, okay, we're going to regroup and we're going to find these thin people and we're going to make it work. And now it works. So it absolutely was studied in overweight people. It didn't work, and so it's actually dishonest.
Yeah,
But the problem, I'm sorry, go ahead.
Stop apologizing.
You go.
So the problem, though, Anise, is that you've gotten away from the actual question, which isn't the technology or the company, but direct-to-patient advertising. And I will say that there's some component of a rising tide raises all ships, and direct-to-patient advertising may have that positive effect, not talking about Inspire as a device, but talking about direct-to-patient.
Yeah, even when Lunesta started putting ads on TV and stuff, I had a lot of patients come see me about sleep disorders, and they didn't end up on Lunesta, but there was a rising tide aspect. So I think it's a good thing that these patients are coming out of the woodwork. Just to Nisa's point about the BMI thing, that Rena Mara has that registry, that ADHERE registry, and BMI is a very strong predictor of failure in terms of it's not that it's not studied, it's well known. And based on the mechanics of the airway, it's predictable that the BMIs will, higher ones will do poorly. I think 32 and lower is better. 32 to 35 is a bit of a gray zone.
Quick poll of the panelists, including Dr. Friedman, one-word answer. Of patients who have come to seek your counsel who overtly mention, I saw this thing on TV, can you explain it to me? How many of them have you put on Inspire? Dr. Das?
0.
Dr. Malhotra?
Couple percent.
Okay.
1 or 2.
Neil?
Small amount.
Okay. Audience take on this? Appropriate, thumbs up, problematic, thumbs down. Give me your paddles. Yeah, they're with me. Yeah. All right, a couple of people, good, all right. Good discussion, thank you. All right, just baby fat's the next topic. Like, how and when should obesity hypoventilation success treatment be assessed? Dr. Wolf.
Thank you. So the recommendation from the American Thoracic Society is 3 months for patients who are coming to you from inpatient ICU stay. And I'm assuming that that's what you're getting at. The biggest thing that happens over that time is significant fluid shifts that are seen in these patients that really impact their control of ventilation in a big way, especially centrals that occur due to aggressive diuresis, since the vast majority of these guys, when they present to hospital, have significant lower extremity edema, the vast majority of which is diastolic dysfunction related. But if you try to make things perfect before those fluid shifts are completed, all you do is get them to blast out into centrals. And so I think it's very important that we look at therapy to get them out of the hospital that includes ventilation, and that it's very important that at 3 months, we look at a step back approach.
What metrics? So again, how would you assess it? So you're talking about the temporal time frame. What are the metrics that you use to assess this is working or not?
At the 3 month point?
Yep.
Full polysomnography.
Retest. Dr. Das?
So you didn't talk about, when we're talking about ventilation, serum bicarb or blood gas, because that's the other piece. So when I looked at this question, I was looking at it differently. I was actually not thinking of the patients who come out of the hospital. I was thinking of the patients, so my clinic is a bariatric clinic, so I have a lot of these patients. And I think, and so my folks, I reassess between 2 and 3 months because they tend to not be as sick. And if in your patient, I think you ultimately need to do a blood gas, not serum bicarb, because they're getting tons of diuretics, and the diuretics are going to cause a metabolic, an alkalosis as well, so which is going to confuse the situation, right? In my patients that are not on diuretics, I often try to get a blood gas and a serum bicarb at the same time, and then I track the serum bicarb down the road. As long as their oxygenation is fine throughout with just CPAP and they're a safer patient, I do not make them get repeat blood gases unless there's a concern.
I will tell you, you're going to see in the literature that the bicarb cutoff should be 27. I'm just going to give you guys my opinion. There's no data on this. I actually use a cutoff of 30 because I feel like in the real world, if I get a blood gas on everybody with a bicarb of 27 or above, nobody's going to come back to my clinic. And then the other thing is that to
Maybe they're voting with their feet. But.
And then the other thing that I use as my cutoff to screen for when a metabolic alkalosis may be driving some of those numbers is to look at the serum chloride. If the chloride is under 100, then there's a significant metabolic alkalosis component that's driving it. And so that's just the numbers that I use to get me through the day.
So in reality, if you have a patient with an elevated serum bicarb and you do a sleep study and they have a little bit of hypoxemia, but you put them on CPAP and you do a titration and their oxygenation is fine and they're doing well, why do you need a blood? I'm going to challenge you. Why do you need a blood gas? Because they're on therapy for probably OHS and OSA. They're going to get better. Why do I need to get a blood gas? What value am I going to do by increasing the? I mean, blood gases are not without risk.
And it does, and they're uncomfortable and stuff. It doesn't really change management. The Pickwick study compared BiPAP and CPAP and obesity hyperventilation, the outcomes are the same. So I think they'll end up on CPAP, and you could argue that, but it doesn't really change management unless they're refractory.
Do you agree with that?
And actually, I think you're agreeing with me, because what I was saying is that I'm just following the regular chem panel that they're probably sitting in their chart from their primary care
I always
doctor.
look if they're on steroids or diuretics, then the bicarb's high for other reasons.
Yeah,
Otherwise,
then you need a gas, yeah.
Yeah, and that's why.
Well, if they're still hypoxemic, I get gases too,
the
because
other-
I'm not sure.
Yeah, I agree. The other thing I'll say that is embedded in the question, but we haven't addressed in terms of how do you assess success. One is patient-reported outcomes. If patients are doing fine, then I'm winning. The other thing is body weight, right? We kind of ignore that too much. I'm running a big study, full disclosure, for Eli Lilly on tirzepatide, which is a GLP-1 agonist to treat sleep apnea. And the weight loss that they're getting is 26% weight loss that they published in New England Journal in June. 26%, so if people are 100 kilos, 220 pounds, 26% weight loss was 55 or 60 pounds, and still hasn't plateaued at 1 year. It's like amazing in terms of how well that's doing. They have new generation drugs that look even better than bariatric surgery. If you look at the Cherno study in New England Journal about weight loss and CPAP and sleep apnea, weight loss was actually better as far as CRP and some other outcomes are concerned. So I think we as a field in sleep have ignored weight loss too long, and I think in terms of success of treating obesity hyperventilation syndrome, body weight is one of the things I'm looking at.
And if you look at the quality metrics from the AASM, you should be looking at weight and weight control at every single visit for not just obesity hypoventilation, but all of obstructive sleep apnea.
Yeah.
Quick follow-up question. So Dr. Wolf had mentioned in the context of a discharging patient from ICU, presumably with hypercapnic respiratory failure, ventilation. So does your treatment of choice change from PAP to bilevel or some ventilatory mode in the context of a discharging patient who'd never been on therapy before for OHS? Anissa.
Discharge patient.
On their way home from the hospital. They've never been
Like,
diagnosed before,
you
admitted with
ended up in
hypercapnic
the
respiratory.
ICU.
Are you more inclined to use a mode that will give them some inspiratory gap and increased tidal volume than you would be in sort of the classic diagnosing at home stable situation?
Yes, and I think that, I mean, that's consistent with the ATS guidelines as well, that you can do it. And that, but then you need to repeat and potentially get them off. So unfortunately, a lot of these guys are ending up on ventilators because that's a whole nother issue is the insurance problem is they can't
Yeah,
get the
can I-
cheaper, most appropriate thing,
Can
right?
I
That's a huge problem.
can I do a shout out here for the OnMap?
No.
Chair prerogative, yes, you can. Go ahead and shout it out.
So
Anissa got a point for dissing you, but I'm going to let you shout it out anyway.
No, the one thing I will say is that I agree with these guys. I would encourage anyone to look at the OnMap documents that were published by CHEST this year, looking at the recommendations for the ways we can make it better, so that you can look at a patient who's clearly in respiratory failure, ending up in the ICU due to obesity, and that we can get them a bilevel with backup rate, which is what they need to go home, but do it on a device that's a RAD, a cheaper device, a more portable device, and we can do it with guidelines that will both save money for the government and save money for the patient. Why I don't understand why they're fighting me when I'm saving them money, but I'm working on it.
Last word, Atul.
It's easier to get a mechanical ventilator than a CPAP in
Yeah,
that context,
the
which is
problem.
silly, right?
Yeah.
But you have to get them off. Like, that's what we do, right? Is they come out on those
Step back.
stupid machines and then we get them on.
All right, moving on. Central intelligence is the next topic. Should isolated central sleep disordered breathing be treated? Dr.
You said
Das.
sexual intelligence, and I was like,
That'd be a
what?
much
You get a
more fun
point for giving me a
discussion.
tiny giggle for mishearing. Who knew that the inability to hear adequately would get you a point? I'll let you start though.
Yeah, so I actually often do not treat it unless the patient is super symptomatic. And I think, and I'm,
Sleepiness?
yeah, if they happen to be sleeping, there are some patients who are sleepy with it, right? If I have a completely asymptomatic patient, I don't always because, and this is something I did research again, there's not outcomes data on central sleep apnea. Like I will ask either of you, tell me what the danger of not doing this, because I stand by, I do treat some of them, but I don't treat all of them.
Dr. Malhotra.
That's very strange sexual intelligence. I think it depends on what we're talking about here. Is it chain Stokes? Is it opioids? Is it complex apnea treatment emergent? And their data on each of those contexts. Chain Stokes has prognostic utility, although intervention is, mainly optimizing medical therapy. Doug Bradley just presented the results of the Advent-HF, which looks to be negative. In terms of opioid things, I think it is important to try and get people off opioids. I think that's just a thing. Danny Eckert, my trainee, had a review in the Blue Journal that came out yesterday, I think, on opioids and that. And in terms of treatment emergent centrals, we have data on rescuing that with ASV and stuff, but I think in aggregate, most of those patients get better on their own. So I think it differs.
Yeah.
But I also think that, okay, so I have a different patient population than most, but one of the big things that I see driving that is the high uses of baclofen. And the baclofen's necessary for their underlying disease. And so I think that you can't just say central apnea. I think it's too diverse, it's too
Bless you.
broad, and you're going to have to look at the very specific situations.
I like how Dr. Malhotra end-runned around referencing himself by referencing his trainee's paper. Presumably, you were an author on that. I will not. I hypothesized you. All right. Wherefore art thou? What is the current role for over-the-counter wearables to monitor sleep for the purposes of healthcare, Dr. Wolf?
Wait, can you explain the question? real
Over-the-counter wearables. So anything you can buy that allows you to track your sleep. Is there any? When they come in, the patient's like, "Oh, look, I'm getting 20% deep sleep and 4% REM." And is there any utility to this?
Yeah, other than making more appointments at my office? No, I do feel
It's good
like.
for your bottom line.
Yeah, I
Then
guess.
voting with their feet, then.
Yeah. I definitely have to say that I feel like this is one of these overprivileged first world problems of, I mean, this is the kind of thing where I'm sure you guys have the same thing. The dean's office calls and says there's a donor whose iWatch is telling them that they have poor sleep. They have no complaints. They have no issues. And they come, what are you going to do with that information?
I wrote a paper about it.
I have a friend who wrote a paper that. I think there is some upside to this stuff, and that's patient engagement, right? So I think active patient engagement, works well with CPAP, it works well with smoking cessation, it works well with weight loss, it works well with all these things. So I think the fact that patients are tracking their data and taking things seriously, I think is a good thing. I always talk about the 3 pillars of health being diet, exercise, and sleep. I think they can track activity, they can track sleep with these things, tracking diet. I think it's a good thing in that context. Yeah, they come in with information that's not actionable, but that's part of the conversation.
I think it's part of the patient that you're dealing with. The worried well who actually make themselves sicker, obsessing over their numbers, are going to have a problem.
But there's others that actually benefit from from diet, exercise, sleep, focusing on all 3, and they do better.
And I think
Yeah,
again, it
but
helps
they
with-
also don't show up at your office.
But it helps with awareness
that.
of hours of sleep, right? I think that I remember Barb Phillips and I were talking about this a couple years back, and that's the biggest factor is that it tells patients, oh gosh, I've only been sleeping for 5 hours for the past week. Maybe I gotta get more sleep. So I think that's helpful.
Unless it tells them they slept 5 hours when maybe they slept 7.
And I think the other thing is we have to be very careful if we ever look at literature on these, unless it's randomized, we're gonna have healthy patient bias. Because patients who are gonna actively be tracking things are gonna always be a little bit healthier and proactive, right? So we have to be really careful. about
Healthy
looking
user
for-
thing,
Yeah.
I think the validation that Ian Coleraine and those people in the Stanford Research Institute, they have pretty good validation data comparing Fitbit to PSG now. It's not bad. I mean, it was garbage 5 years ago. It's better now.
2 more topics. Don't be a dope. Is there any role for dopamine agonist therapy for restless leg syndrome in 2022? Dr. Malhotra.
I still use Mirapex or Pramipexole. I often use it, and I don't see the downsides that people are saying, that all this augmentation stuff. If they get that, you can deal with it. But yeah, I still use it.
First line?
Sometimes, yeah.
Okay. Dr. Das?
Rotigotine is my best friend still. If I don't start it with it ever, I actually start I've shifted, and I'm more of a start with gabapentin kind of woman, just because of the European.
Generic gabapentin, not enacarbil.
Not enacarbil,
Okay.
yeah. But when patients have a hard time, I mean, we're taking things, it is, if they can afford it, the problem is it's a huge cost factor. I think there's less augmentation with it. You can still have augmentation, and there's less rebound with it. So I think you can't say them as all comers.
The only other thing I would say is that, like everything else, you've got to look at your patient's phenotype when you make a decision about what you're going to treat with. And if this is someone who's got a history of significant neuropathy, there's pain along with their restless legs, then obviously that person's going to do better with gabapentin. On the flip side, people who have a significant family history and need to have a drug that's going to be more directed, dopamine agonists are great, but the one point that I'm going to make is all these guys should be screened for iron deficiency before we make any decisions about actual drugs.
Yeah.
So you both, sorry, go ahead.
No, let's say gabapentin worked great until it went generic, right? It was one of those things that was one of these agents that it's like, oh, it's generic, it doesn't work. Yeah, let's try this more expensive version of the same thing. I will say in California, it's really hard to get some of these more expensive drugs, like Nupro and stuff. I just can't get it very often.
I'm actually surprised. So again, in Georgia, this is not like, but I sometimes have to call in patients. In some places, how many of you live in a state where gabapentin requires a controlled prescription? Like, that's messed up to me. Like, I've never lived, where you have to actually give them your DEA and triplicates, and that's kind of crazy.
But the insurance doesn't cover the more advanced drugs, at least in our experience, like Horizon and stuff. I can't get that.
So from the panel, Dr. Malhotra, you'll still use a dopamine agonist first line. Dr. Wolf, you will. Dr. Das, you will not. Show of hands from the audience. How many of you will use dopamine agonist first line therapy for RLS still? About a third, quarter to a third. Thank you. All right, one more formal topic. Idio killed the radio star. Do we have any idea how to define idiopathic hypersomnia definitively? Dr. Wolf.
I don't know, you're the one hanging out with Dr. Trotty, you tell me.
Well, okay, I'm not giving you the answer. The question is, do you know how to define it? Maybe I do.
Yeah.
I don't.
Look, I think that we have total sleep time parameters, we have, MSLT parameters. I think all of this is going to be just a good shot at it. I don't think anything is going to be perfect. And what I want to say really quickly in terms of the total sleep time components to this is that, we have a lot of people for whom their school times say you have to get up at this time, and that between that and practice and whatever for kids. And for adults, it may be work time plus other family activities. That if what you actually need to stay alert is 9.5 to 10.5 hours of sleep, then what happens if I say, well, you're fine, but it's not realistic for your life?
Yeah, but it's not idiopathic hypersomnia.
It's
And
not
first, it's not. It's
it's not.
insufficient sleep. And yeah, you're tired, but it's not. And so that's the problem.
Even at 10.5 hours of total sleep time?
Yes, it's
I mean,
not. It's not
the
idiopathic.
long sleeper
You're a long
phenotype, is it
sleeper,
real?
Yeah. So I think it's a gamish. That's idiopathic hypersomnia
Yeah,
by virtue of the
it's a
title.
basket.
Has to roll out everything else.
get a point for using the word
period.
gamish.
And we overlook so much crap into it all the time. There's circadian rhythm disorders, I think people ignore all the
Yes.
time. I think that I'm a big believer in social jet lag. I treat that all the time. I think a lot of people have that. I think it's way overdiagnosed personally. So I don't
Yeah.
think so. And then the other thing is everyone here probably knows, right? So you do your PSG MSLT, and if they don't meet criteria, meaning that their MSL is too high, then you're supposed to do the 24-hour PSG or the actigraphy to show how many people actually do those? How many folks have actually done a 24-hour PSG on a patient? Right, because it's not feasible and it's not reimbursed.
Yeah,
So
we do
don't
the
those.
actigraphy.
Yeah, you can. Yeah, actigraphy you could do.
We do actigraphy.
But the problem is, who has 10 days where they can sleep as much as they want and it doesn't affect their work? And if you can, then why are you seeing me?
Well, so you're making my point. You're agreeing with me.
So we did, I should disclose again, so Jazz Pharmaceutical did a global consensus thing, which is currently in peer review. And one of the questions that was addressed was this one. And you do have to rule out all these other things, but interestingly, MSLT and actigraphy, neither of those were sort of required because they're not globally available. And so we had people from Europe and other places just saying, sorry, we can't do that. We don't have access to MSLT or actigraphy. So.
And can I just make one other point? Because this just is something that pisses me off. We're trying to be very elegant here about phenotyping our patients, trying to cohort patients into disease groups that make sense from a biological basis. And somewhere down the street is a psychiatrist who's telling them they all have ADHD and handing out methylphenidate.
Yeah, that's a good point.
Yeah. Okay, all right. But all right, I want to say one more thing about this. So, and this is why I really, really don't think that we know how to diagnose it. So I talked about the steps, right? MSLT, PSG, we talked about the 24-hour test, but then if you go to the ICSD and go in the paragraph, so find this, if you go there, it also says, also you can make the diagnosis if the clinical physician really thinks it is the case. So basically,
That's where we end up with this
yeah,
consensus.
so basically, at the end of the day, you don't have to do anything you want if you're like, yeah, I think you got it.
Yep.
So I'm like, so no.
Yep, yep. Outside, you'll see the queue up of psychiatrists ready to hand out the drugs.
Very close. I'm going to give one more question. I'm going to let the audience score this. So what I'm going to ask you to do is let all three competitors answer this next question. They don't know, they haven't seen this question yet. So, and then depending on the percentage of the audience that gives a thumbs up, I will give some fraction of 4 points. So this is anybody's game right now. Here's your final question. Please let all the competitors speak before you vote. What television series had the best finale and why? I'll give you a minute to think about it. Oh,
wait.
Dr. Wolf wants to come in. Jump in.
Gilligan's Island. They got off the island.
They got off. That's all you needed was they got to get off the island.
Okay, this is such a girl thing. Who loves their telenovelas? Okay?
Nobody.
Nobody raised their hand.
Yeah.
Ugly Betty. Ugly Betty.
That's not politically correct.
Why?
That's what the show was called.
That was the name of the show.
She called herself Ugly Betty.
Yeah.
Why was it the best?
Because at the end of the show, she was the beautiful together one, and the previous rich uppity guy was standing on the corner with no job and no future. So it was.
Anissa Das.
So I actually like the callback. So Sex in the City. I think Sex in the
No
City.
voting yet. No voting yet, team.
All right, so all I'm going to say
You
is
can
Sex
give
in the
it-
City. I'll
why?
skip it. Sex in the City because I think it.
How many times have you said sex during this thing?
A lot. A lot. I'm going to give you a point for that. That was good.
That's just like begging for points.
He knows her, I think.
Pandering.
Why?
I think that it gave full closure and everybody was happy about. It's something that you've been waiting for the entire time.
All right, so you can vote based on these answers or their overall performance, and you can hold up your little thing 3 times if you want. So you can vote for everybody if you want. So, Dr. Das, how'd you do on this question overall? Give a thumbs up if you can vote for everybody. All right, I'm going to give about, wow, a thumbs down. Zelensky, damn, you're hard. All right, we'll give you 2. You can't raise your hand. Dr. Malhotra, how do you do? All right, get 3. And then Dr. Wolf, how'd she do? All right, I believe I'm going to give 2 points to Anissa. I'm going to give 2 points to Lisa, and the winner, Dr. Altul Malhotra. Please, a round of applause. Well done. I do have a winner's thing for you, but before we break, we have about 7 minutes left, or 8 minutes. Dr. Friedman, you've taken pages of notes. I'm going to hand the podium over to you to kind of run us through where they were right, where they were wrong, what additional points you want to make.
Would you like me to stand over there?
Why don't you stand over there, then we can yell at each other across this room, yeah. Because otherwise the shine off both of our heads would be blinding to the audience.
Exactly. Well, so first, thank you to everybody, certainly on the panel and everybody in the audience. So Dave, here was my take home. I'm not really quite clear that we answered any question, and we may have actually confused the audience even more. It does appear that sex does get some extra points. So here's my, I took 3 pages of notes here. So in terms of things that I think were pretty consistent.
Shouldn't have to take notes about sex, just putting it out there. So,
You can still lose points, Dr. Malhotra.
I am a new empty nester now, so maybe I do need to take some notes. So I think in terms of things that were pretty clear, I think dopamine agonists people use them and still feel okay with them, whether they're first line or not is not clear. I think that it's really not clear what the best measure of cardiovascular risk, and in terms of whether CPAP should be used in patients with, who don't have daytime sleepiness. I don't think we have a great answer there. And if you certainly look at the data based on, stuff by Barbet and the SAVE trial and the Ricazza trial and all that other stuff. I mean, to me, it's not really clear. I know the arguments is always that people who are not sleepy don't use their CPAP, and their CPAP utilization in those trials were under 3 or 4 hours. The reality is maybe they're not using it because they don't see any benefit. What else? I think we had some debate on aggressive use of advertising for Inspire. I do like I mean, I'm annoyed by it But I do like the argument that it gets more people in the door just to talk about sleep in general.
And you can build a higher level of service because you spend an extra 10 minutes telling them what Inspire is, because the ad doesn't mention it at all.
Well, that's.
Just
I
no
guess.
mask.
Right. I do, you know, my take home on some of the over-the-counter things, I actually think they're pretty good. Again, gets people in the door, and look, I'm no expert on technology, but I do think over time, these devices will get better, and their ability to, you know, total sleep time is probably pretty good, and I think looking at changes in physiology in terms of heart rate, and now with the watch,
There's an oximeter on that thing.
yeah,
too.
I
It's
was
a
just
matter
going
of
to
time
say, yeah. In terms of oximetry, and we know the changes in physiology that occur in REM versus non-REM, I think actually we'll get some really good data. Maybe it's more engaged patients, maybe it's not. So, you know, I think take home, at the end of the day, there's still a lot of art to medicine, right? You know, there's a lot of things that are not very black and white. That's my take home, Dave.
We have about 2 minutes or so. Questions from the audience? Yes, sir.
Peripheral arterial tonometry home sleep testing device.
Great question. Pat Devices team.
What's the question? Good or bad?
Bad, ugly.
He's just advertising them.
I think good, but
You know,
yeah.
I hate them.
why?
I hate them because I like to look at the data myself, and I think it really limits the amount of data that I can have. It might be good for somebody with severe sleep apnea, but I'm missing so much information.
So there's some papers by Malhotra that have looked at the validation,
I'm still taking points away, by the way.
and, you know, the validation's pretty good. There's a disposable one, which a lot of patients like, actually. It's about $100, and you can retest and stuff. And so getting the area into the curve. I think it also has some appreciation for sleep. It gives you total sleep time. There's a REM detector on there that's actually FDA approved and validated and stuff that's okay, not great. So I think it's better than most home sleep tests, I'll say that. But the other thing I'll say as a field is it's not a stroke of engineering genius to measure a brainwave or something. I don't know why we're not getting sleep staged on a regular home sleep test. It's not that complicated. We should just insist on it.
Lisa, Pat
And
Devices.
Yeah, so the thing that I would say about it is, the thing we say in our lab is the first rule of WatchPat is don't discuss WatchPat. But beyond that, the thing that I really am happy with it is that I have a lot of patients with neuromuscular disease that are using PAP therapy, and because of their physical disability, can't get in easily for testing. And I love the fact that I can test them with their PAP on, which isn't really an option with most other devices, and we use it for screening to make sure that they're adequately treated. You have to score it differently, right? I'm not looking for apneas and hypopneas. So in some ways, it's like God's most expensive pulse oximeter, but it's very patient-friendly that way.
All right, we had one more question right behind you. Yeah, please.
So my question would be, gabapentin is considered a very benign drug by neurologists, and I guess, from what I'm hearing from the panel. But from falls to gastroparesis to central apneas, I don't know, there's a threshold of gabapentin beyond which I think you start seeing central apneas, and it's very widely prescribed. And I've tried to cut back in some patients in the repeat sleep study, and it does get better. I had a patient on 1,200 milligrams 4 times a day. After 6 falls in 3 months, and then cutting back on the gabapentin, the GERD symptoms got better and the central apneas got better. So that's A. The second thing is that, you talk about oxygenator and the sleep studies. Sometimes you see somebody with moderate sleep apnea and the oxygen going down really low. That's when I do a lung function test on them, and sometimes you diagnose lung disorders. And the third thing is, I can barely get a bypass in hypercapnic patients. I don't know if have you had any experience getting a CPAP? Because Medicare really doesn't pay for bypass, even with the second. And then with the national shortage in backup, you have a patient you have to discharge tomorrow. I don't know if anybody's had any experience in getting Medicare patients bypass on the day of discharging.
So I'm going to tackle the first and the third question because we don't have a ton of time. So the first question is, are we too blasé about the use of gabapentin in the context of the potential for significant side
Yeah, I'll add
effects?
2 things to what you said. One is weight gain, which I've seen that with high-dose gabapentin, which people don't talk about, but is a problem. And the other thing I see, I work in the ICUs as well. You see withdrawal from that too, which people don't talk about, but people withdraw from that drug when they come in. You see all kinds of crazy stuff. So I agree, it's not a benign drug.
And then in terms of, Lisa, do you want to speak at all to getting trying to get a bi-level machine from hospitalization?
Yeah, I mean, the problem is, that's why we end up using a lot of mechanical ventilators for these guys, because we can't get straightforward bi-level devices paid for. And I think that it is a problem that is not only costing insurance companies a lot, it's costing patients a lot. And that's why, if you're going to use it for the short term, it's important to step it back. And it's also going to be important for the new recommendations that the HPAC is looking at to change things, to make it better. And so what I will tell you is that, in full disclosure, the HPAC team did meet with Medicare in terms of CMS nationally, and what we've been told is to get the changes that we need, we're going to have to go to each division of Medicare separately, so local coverage determinations are going to be necessary for every segment of the country. It's going to take us a lot of work and a lot of time to get there, but it is really, at this point, the only hope of saving the problem you're talking about.
And with that, we are at time. Ladies and gentlemen, please thank our panelists, Dr. Wolf, Dr. Dawson, our champion, Dr. Malhotra, Dr. Friedman. Please take those paddles. Don't take them home with you. They won't fit in your luggage anyway. Drop them off in the back. We'll be using them iteratively, and have a wonderful rest of Chess
Thanks, everyone.